Thank you, Polly. And yeah, so I'm really happy to be chairing this session this morning, and I think it's great that we're able to share some of the work that two of the chorus teams have been doing around community engagement and the role of community advisory panels or whatever they are called in the different contexts. I know that you kind of each have groups that you're reaching out to in the community to inform the work that you're doing and to build a good relationship with the communities where you're working. So we thought in chorus it would be really useful just to share some experiences of trying to do that, particularly in quite complex urban communities where we're working, where even the term community needs analyzing to see, who is actually making up that community. And communities are very transient, and it's, it can be a real challenge to work out how best to bring people together. People are really busy. How do you deal with all of those issues in the urban context? So we thought it would be really useful just to hear from two of our teams on their experiences of doing that and the lessons learnt through the process. And I think some of the lessons come directly from chorus and from the project ones, but also I know that lots of teams have got experience of doing this over sort of many years now. So, and building up those relationships both with communities and with patients. So we are very lucky to have the team from University of Ghana School of Public Health. So we have Ada and Lauren presenting for us first. And then the second presentation will be from Deepa and from Romana from ARK Foundation. And so we will have about 10 minutes for 10 to 15 minutes for the presentations. And maybe we just have, like, if there's questions for clarification, we could just have a few minutes after each presentation. And then after both presentations, we've got some time for just open discussion, where I know lots of you have got loads of experience of trying to engage different communities in the urban context. So we've got time for everybody to talk about that and the lessons learned and see what we can really sort of capture and synthesize as key lessons from our work in chorus on this. So without talking too much more, let me hand over to Ada and Lauren from the University of Ghana, who are going to talk about their experience of working with the communities in Accra.
Thanks, Helen. So, good morning, everyone. So Ada is, she may be joining us a bit later. So for now, I'll do the presentation. So we want to present our findings so far from using the concept of community advisory groups in our chorus project 1 for Ghana. So the first question was, why did we form the community advisory group? Now we've also called it, we've called it a technical advisory group as well, but now we also have a technical working group at the national level, and I think that's making it confusing. So maybe we should start using the CAG instead of the TAG. So I have both of those terms on this slide, and I understand from the literature there's also a lot of different names for these kinds of groups, but initially, we started using CAG, Technical Advisory Group. So why did we form them? Well, we are using a participatory action research approach. So aside from the point that the perspectives of the communities are important, we also wanted to make sure that they were engaged in all aspects of the project. And that they had a voice in validating the findings, and then in terms of the next steps in terms of the action steps for the project. So we created a terms of reference initially because we realized we needed to have clear objectives for the reasons for the community advisory group's existence. So we have three key objectives. The first was to co-create the intervention package with the research team. And then also, secondly, to liaise between the community and the research team during the implementation of the intervention. And also three, as implementation is ongoing, the research team would share, the idea was that they would share updates with the CAG and also engage the CAG in any areas related to troubleshooting or areas of concern as the intervention is being implemented. So those are the three key sort of objectives that we had at the outset for the technical advisory groups. So how did we form them? So, you know, in the Ghanaian chorus team and the project, we have 2 municipals in the intervention areas. And in each of those municipal intervention municipals, we have 2 communities, and they are really not communities. As Helen said, community is like an overused term, but it's, when we use it sometimes, we are describing like a huge geographical or population that's very diverse. So we use communities, but really they're actually sub-districts, which are quite large areas. So we have 2 of those in each of our intervention districts. So we wanted to form community advisory groups, 1 for each municipal, but we wanted their composition to consist of relevant persons from our 2 sub-municipals in each of the municipalities. So we thought that we didn't want to make, from the literature, we understand that we didn't want to make the community advisory groups too large because it would be difficult to have meaningful discussion. But at the same time, it was hard to figure out how to create them because our areas are so diverse, our urban areas. And then we also, as part of our chorus work and our Ghana Project 1, aim to engage not only with, you know, communities and their associations, but also with local government and also health workers. So, but in the end, we decided to have 8 members from each of the sub-municipals. So we ended up with 2 16-member community advisory groups, 1 for Medina and then 1 for Ashaiman. And how we selected them is, I think last week or the week before, we had the case study, the impact case study webinar. And in that webinar in Ghana, we were describing how our directors of health for the 2 municipals, the intervention municipals, are embedded as researchers within our team. So we relied on them a lot when we were thinking through the composition of the community advisory groups. And also we had done a comprehensive stakeholder mapping and analysis as part of our needs assessment for Project 1. So we had mapped the stakeholders and their interests and their power and political affiliation, which is important in Ghana. So we asked them, the district directors of health, initially to come up with a list of 16 members for each municipal, 8 from each sub-municipal, with a balance. We gave them criteria with a balance of members from local governments, associations, which in this case, we have a number of community associations that represent vulnerable groups and different kinds of workers, and then religious and traditional leaders, and also health workers and community health committee members. So they came up with a list and gave it back to us. And then we looked at the list again as a research team and tried to make sure that we had a balance. What we found initially is that we had some of the, for example, the municipal coordinators for CHIPS as members of the CAG, but in the end, we decided that we wanted to really balance the voices of the health workers and the community members. So we ended up liaising with them more as sort of like coordinators, and we had health workers on our CAG, but yes, so we had some of those considerations, and also in Ghana, as I mentioned, political considerations when you're dealing with local government. So you don't want to have, you know, only maybe a representative from one of the parties, or you want to try to balance those dynamics. So those are all the considerations that went into their formation. So far, how have we engaged the community advisory groups? So in October of last year, we disseminated the needs assessment findings to them, and at the same time had an inaugural community advisory group meeting in both municipals. And at that meeting, we presented proposed intervention areas. So these were broad areas of intervention, which we thought as the research team were relevant. For example, awareness creation about CHIPS, increasing CHIP service coverage. And we sought their perspectives. And we used participatory ranking approaches. So we had flip charts, we had Post-its and markers, and we went through each of the intervention areas, and we had them individually come up with their ideas, and then we actually summarized them all, and then came up with a more consolidated list together as a group of the areas. And also we wanted to engage the CAG at this particular meeting and in general as a way to garner community and local government support to drive sustainability, because our intervention does require resources, and we know that after we leave the community, they may not be available. So we wanted to also form subcommittees focused on resource mobilization with point persons who would be committed to also mobilizing resources for the intervention. So what did we learn so far? We learned that, just as we've learned in the broader work we've done with Chorus in Ghana, in the urban context, we learned that respect for the community advisory groups members' time is really important in the urban context, because they are busy, and every time they meet with us, they take time away from their work, and it's important to compensate them. And again, this is also a larger finding from the Project One work, is that it takes a lot of time and patience to build trust or rapport in urban settings. So if you're developing a community advisory group, you can't just go in at the start of your project and say that, okay, we have this project and we're going to need a community advisory group. It takes time to map the stakeholders, to understand them, how they interact, and also to let them see you as people they can also trust. So the fact that we had done this extensive needs assessment before we developed the community advisory group helped, because by the time we got to that stage, they knew us, they had seen us a lot, and they knew what we were about and the project objectives. It was and is important to balance power dynamics, because the advisory groups consist of people from a lot of different educational backgrounds and socioeconomic status, and political affiliations. So, for example, in some of our earlier engagements, we found that the health workers, because they're very confident and educated, were very vocal in the discussions, but we needed to balance their contributions with those of other individuals. And of course, when you have people from local government, like assembly members on your community advisory group, they sometimes see it as an opportunity to push their political agenda. So you need to, while you need to include them, you have to carefully balance their contributions in a way which is also polite. And then, so we did moderate the sessions. The research team moderated the sessions, the meetings of the CAG, as a way to try to ensure a balance of perspectives and participation. And then we also made sure to hold the sessions in a way that participants could contribute in both English and also local languages, because in many cases they were more comfortable speaking local languages to articulate their opinions and views. What would we do differently if we had to form a new community advisory group? We struggle with this question, I think, because we're still in the process. But when we were reflecting as a team, we realized that it will be good to have more regular communication with community advisory group members beyond just communication about the meetings, because in our context, they really appreciate regular updates, and then they appreciate that beyond the research project, you also are concerned about their welfare, as people, as communities. So when you have that regular communication, it helps to build rapport with them in between meetings. of course, it's a tall order because we have so many commitments as a team. So, making, part of the to-do list to, call CAG members and update them when there's, like a long pause between meetings is important to, sustain their engagement and also make them feel included and make them feel that you, of course, are concerned about them as communities and people beyond just seeking information from them. And we realized that we did our best, but we realized that we have a long way to go as researchers in learning how to communicate in lay language and also breaking down concepts using interactive methods. We tried to use visuals, but probably development of more graphics and videos to explain concepts would also be useful. Again, also time intensive, but important. And we should have done, it would have been good to do a pre-survey to assess the perspectives of the members of the community advisory groups before we started working with them, to also show changes in their capacity or behavior. And that could also feed into the impact case studies, although we can still do a post measurement or other more qualitative forms of reflection with them. And then also would be important to focus on understanding the capacities that the people on the community advisory group want to build as individual leaders or members. Of course, they get some compensation and they appreciate that. And they also have, as people who do a lot of volunteering, they're on a lot of these, they do a lot of these engagements. There are people who are interested in bettering their communities, but it will be good to also understand where they are as individuals and if there are certain capacities or understandings they also want to build as a result of their engagement in the community advisory group. So that is what we came up with, and we look forward to your questions and your discussions. Thank you.
Thank you so much, Lauren. That was really interesting and great to hear the sort of reflections of the team as well, and that real kind of critical reflection that you've all gone through in terms of how you're engaging. I think that's just really, really helpful. Were there any quick points of clarification anyone wanted to ask? And as well, do feel free to sort of write things in the chat as we go. If you think of a question while someone's talking, or even if you just want to share an experience from your own work as you've tried to engage different people from the community. Okay, I can't see any hands. So, oh, Romana, sorry. Yeah, Romana, sorry.
Thank you, Helen. We have a presentation and Deepa will do the presentation, but I also have a question for Lauren, and thank you for the nice presentation. So my question is that, engaging community and making them understand about the research requirement, we found this quite tricky. And they always, in different occasions, they ask that what benefit they are getting from the research, and how they can meaningfully contribute without proper understanding of the research. And sometimes they also ask that can they get some training on the proper research. So how Lauren and the team made the balance of providing training or some capacity development of engaging them in the research methods, and whether she felt faced any challenge and how they overcome those. Thank you so much.
Thanks, Romana. It's a good question. So I mean, a lot of the members on the community advisor group, some of them were involved in the transect walks and other activities as well. But generally we try to, they are not interested in learning about, research methodology. And it's not something that, I mean, the methodology of participatory action research is relevant to them, but then the larger methodology of like evaluation design, probably not so much. So we try to keep the methodology section shorter and use visuals when we were engaging them. and try to consider, what would be relevant to them, and also try to consider their time. And so what would keep everything sort of moving along. But yeah, I can't say that again, it would be good to ask them specifically what they want to learn. Because we always think of research skills, but there's way broader skills they may want to learn as a result of their engagements. So yeah, I'm not sure I have the best answer for you, but those are my reflections. Thank you.
It's a really good point, and maybe we can pick it up in the discussion after we've heard the next presentation from ARK. I think there'll be some useful insights there. So Deepa, can we hand over to you for your presentation from ARK?
Yeah, just a second. Okay, this is strange. I'm just kind of, the option of sharing isn't really working for me for some reason. Just hang on a second, please. I'm so sorry about this.
No problem. Polly, are there settings? It must be.
Yeah. All right. Yeah. It's just a little bit of a, yeah. Is my screen visible?
There we go. Yep, that's good.
Okay, awesome. Sorry for that. So anyway, hi everybody and good afternoon from Bangladesh. So we've come over to kind of explain and share our experiences with the community advisory groups while working with Chorus, especially Project One. So of course, we are aware about what do we really mean by community engagement and community involvement. I'm not here to take a session on it, but I guess one of the main reasons why we really have been involved with the community and have been engaging with the community is to make sure that they are heard. And as we've actually put in answer quote, we wanted it to be less of a research which is conducted by researchers in their office and more of a research conducted with and by the community and the public, for whom we intend to develop and implement the intervention. So I guess that's been something at the core of the project in Chorus for us at ARK. So of course, when it comes to community involvement, as I've mentioned before, prior, I guess one of the things that we used to do was decide upon the research, decide about the study in the four walls of our office room. But then gradually with time, what we've realized is, and this has been with the help of Leeds and York and other partners, that eventually whatever we are designing is for the people and for a particular community. So we really need them to be engaged in this. We really need them to be involved in this so that they feel heard, so that eventually when we are designing, when we are implementing, we're actually doing it for the right reasons and for the right people. And eventually so that the people and the community members feel heard. Of course, we'll be discussing more about this as we go through the presentation. So bearing certain things in mind, we formed something which we call the Community Advisory Group, which is a voluntary group of engaged people from the affected communities. And they advise the board and the management as to how we can address the need of the affected communities. Now, as we've mentioned before, the community active group members that we've actually formed, it was done at every stage of the study. So right from choosing the research questions to designing study, to implementing and to dissemination. One of the reasons why we've done it was, again, from choosing the research question was to identify what needs to be addressed through the study. When we designed the studies, we were interacting with them to ensure that the study design was appropriate as per their needs. In case of implementation, we wanted to ensure that the planned intervention was context specific, feasible, acceptable, and gender sensitive, and so that it wasn't a burden to them. We wanted to be sure that it was helpful for them. And in terms of dissemination, when we do disseminate it in the future, of course, we hope that the findings are suitable to their needs and it responds to their problems. So in terms of the community advisory group, we've formed two of them because we felt we wouldn't be able to bring the healthcare workers and the patients together in one platform. So one CAG consisted of healthcare workers, where again, we've been kind of quite mindful that if there is the doctors and the SACMOs and pharmacists and paramedics in the same room, there is some kind of power dynamic which would come into play. So we've kind of made sure that these are other than the doctors, it's pretty much the SACMOs and paramedics and pharmacists who were a part of the CAG. And on the other hand, we've been involving the urban dwellers, more so from the slums and lower income group people. Now, when it comes to why we actually felt it was important for us to form two separate CAGs. So for the urban dwellers, of course, at the beginning, we really wanted to understand what their perception was about the healthcare system, what their NCD health-seeking behavior was, what were the perception about the urban primary healthcare facilities, their expectations, their suggestions, and how did they think that they could bring potential change into the system. And I mean, these are just some images of us interacting with them. And on the other hand, we've also, as I've mentioned, we formed another CAG with the healthcare workers because we wanted to understand the supply side as to how they operate, how do their facilities operate, the challenges, and actually being empathetic to the challenges that they actually face. It was very important for us to know the patient pathway and how they deliver services throughout, the types of patients who visit the center, to listen to their suggestions, because at the end of the day, the healthcare workers would be playing a very big important role in the intervention. So we really wanted to make sure that we make them heard as to what their issues and their problems were. So anyway, when we were forming the CAGs, especially for the urban slum dwellers, we were in mind that we wanted to make sure that their gender was considered, their NCD status was considered, their education level and employment status. So these were a couple of factors which we wanted to bear in mind, because eventually we are very mindful of the fact that when it comes to the male and female aspect of it, maybe the woman may not be very comfortable speaking in the presence of men, or even somebody who's comparatively less educated may not feel comfortable speaking in front of somebody who's really educated. And of course, employment status does play a role. So we wanted to be very mindful while creating these CAGs. And additionally, when we were creating a separate CAG for the healthcare workers, as I've mentioned before, considering the existence of power dynamics, we tried to be as mindful as possible. So we kind of restricted ourselves to only involving the SACMOs and paramedics and the pharmacists. And of course, the gender aspect of it. Now, once we were able to consider these, and once the CAGs were formed, we had our terms of references. So we made sure that we read those out to them. They had a copy of it. They were very clear about what their roles, responsibilities would be, what would be said, what would be expected from them, and so on and so forth. So again, so one of the important things that we've tried, at least in the Chorus One project, is to constantly engage with them, just not to receive information, but also to give them information as to what progress we've done. So to keep them updated, because at the end of the day, no matter who the CAGs are, be it healthcare workers or be it the urban dwellers, they really want to be felt that they're heard, and then they also want updates. They like being updated in the end. So we've kind of divided it phase-wise. So as you can see, right from the beginning, during the needs assessment phase, we spoke to them, got their thoughts, and then once the needs assessment phase was towards the end, shared our findings. Then again, when the co-creation phase started, we sat with them. Again, we kind of told them that, okay, fine, so these are the potential interventions. What do you feel? What do you think about it? And then once the implementation phase started, we've also been sitting with them since then. So these were more in terms of workshops. Now, key learnings from the CAGs. The overall CAG, I'm going to go into the overall learnings a little bit later, but very specifically, so from the CAGs, which comprise of the healthcare workers, specifically from the urban dispensary healthcare workers, we've realized that they seldom focused on NCD because they were providing a lot of services. Especially the urban dispensary healthcare workers, they felt they were neglected in infrastructure. Their safety was not a concern. They had these sudden job transfers. That when it came to staff support, they had issues. And meanwhile, on the NGO clinic workers, who were also a part of the health workers CAG, they mentioned about the fact of the inadequate medications and the fact that they've always felt neglected by the Ministry of Health and Family Welfare. And of course, that they were too focused on the MCH and SRH for generation of revenue. And from the community advisory group, which was focused on the urban dwellers, we realized which centers they preferred, Why were they a lot dependent towards pharmacies? Why was there too much, very little compliance towards NCD medications? How they were usually neglecting lifestyle changes. Of course, it's not by choice, but it was due to their busy schedules and also stigma, especially in terms of women. And lastly, of course, the fact that they didn't necessarily receive clear instructions or lifestyle modification guidance. So these were certain things that we realized through the CAG meetings with the urban dwellers. I guess what would we do if we had to form, we are still learning, just as Lauren mentioned in the previous presentation. So there's so much that we all wish that we could do. But I guess one of the main things that we've delved into was we haven't been able to involve the vulnerable groups, all vulnerable groups. So for instance, the third genders, we haven't been able to involve them. We haven't been able to involve them in CAG. They were a part of the study at the initial phase, but we haven't been able to involve them in the CAG, especially because, again, we had to be considerate about the other CAG members as well. Hopefully in the next time, whenever we have to form a CAG again in any other project, probably we'll just be a little bit more aware about it and visit them and visit their health facilities a bit more and find a different way of engaging with them. But that's something that we really need to learn a lot more about first. And of course, secondly, I guess explaining everything. The healthcare workers communicating with them was something different. But just as Professor Romana ma'am mentioned before, when it comes to explaining things to the urban dwellers and also based on the literacy, they really do ask about how they would be benefited and what would they be able to expect from these CAG meetings and from the study and so on and so forth. So eventually reaching out in that case is definitely an issue at certain points, but we are still learning how to do that. So anyway, when it comes to challenges and mitigations, so we've had these challenges of ensuring all the participants, especially the females, were participating in the discussion. We've had an issue with the transfer of health workforce. So they were members of CAG, but they'd be transferred. So we'd have an issue with that. All members may not have been available at the same time. There were political and seasonal reasons. The timelines would have to be shifted. But most importantly was holding on to the trust of the community and the healthcare workers. So that's something that, again, as Lauren mentioned in the previous slide, it's not just easy to go there and tell them, this is what we're going to do. Because according to them, we'll just go, speak, and probably we may never return back at all. So holding on to that trust was extremely important. So in terms of mitigation strategies, we've constantly been in communication with them, and we've always tried to update our members about whatever phase we are in or whatever our findings are. And in the CAG meetings, if we found that people were a little bit quieter, the researchers would moderate and try to be a bit more engaging towards people who would be hesitant to speak. And in cases where maybe timelines had to be shifted, we'd try our best to arrange workshops and meetings as per the convenience of the CAG members. So that's from me for now, and that's all of us. So thank you very much for your time and patience.
Fantastic. Thank you, Deepa. Excellent presentation as well, and really interesting to hear such a kind of a different approach and different reflections from the two teams.